Hey everyone, my name's Cody Summers, and I'm an ICU nurse passionate about pharmacology in the ICU. I think it's important that as nurses we understand how these medications work that we're giving to our patients, so I decided to make videos explaining medications. I've created this video series about vasopressors primarily to help my orientees, other nurses, and nursing students, or anyone wanting to better understand vasoactive medications, which play a critical role in critical care. Today we're going to be diving into norepinephrine, commonly known as Levophed, one of the most widely used vasopressors in the ICU and even OR settings. So let's break down what you need to know about this powerful medication and why it's so important to maintaining hemodynamic stability. So norepinephrine, also known as its brand name Levophed, or just Levo, it's commonly referred to in the ICU, is a vasopressor that primarily acts on alpha-1 adrenergic receptors with some beta-1 receptor activity. This means that it causes vasoconstriction, which increases our blood pressure, and can also have a slight effect on heart rate by increasing myocardial contractility. It's a part of the catecholamine family and is endogenous to the body, which means it's being naturally released by the sympathetic nervous system. Norepinephrine is most commonly used in cases of hypotension, especially in septic shock and other forms of distributive shock. In these scenarios, blood vessels are really dilated out, and norepinephrine just helps restore that vascular tone, which in turn improves our blood pressure. When it comes to dosing, norepinephrine is typically administered via continuous IV infusion. At our institution, we typically start our patients at 2 mics per minute, and we will go up to a maximum of 30 mics per minute, though in extreme cases, higher doses may be necessary. For example, I've had patients on 120 mics per minute in our ICU with profound shock, but we typically don't see this. It's important to titrate the dose based on the patient's hemodynamic response. So most often targeting a mean arterial pressure of 65 millimeters of mercury or higher. Keep in mind that norepinephrine should always be given through a central line to avoid extravasation and potential tissue necrosis. Now, like all meds, norepinephrine does have side effects. The most common ones include tachycardia and tachyarrhythmias due to its beta-1 effects. Additionally, prolonged vasoconstriction can also lead to limb ischemia, particularly in the extremities or vital organs if dosing is not carefully controlled. As for contraindications, norepinephrine should be used in caution with patients who have hypertrophic cardiomyopathy or severe peripheral vascular disease, as excessive vasoconstriction can worsen these conditions. So let's look at a quick case study. Let's just imagine you're caring for a patient in the ICU with septic shock. Despite adequate fluid resuscitation, their blood pressure remains dangerously low with a MAP of 55 millimeters per mercury. So you start the patient on norepinephrine at 5 mics per minute. As you monitor the patient, you notice their MAP improves to 70 millimeters of mercury and their urine output starts to pick up. These are great signs that tissue perfusion is improving. In this scenario, titrating the norepinephrine based on their hemodynamic status was critical for stabilizing the patient. So when comparing norepinephrine to other vasopressors like epinephrine or dopamine, we see that norepinephrine is often the first-line treatment in septic shock, specifically in MICU, due to its strong alpha-1 vasoconstrictive effects and lower risk of causing tachyarrhythmias compared to like dopamine. Epinephrine, on the other hand, may be used in more cardiac arrest scenarios, while norepinephrine is preferred in maintaining stable blood pressure over time. So to recap, norepinephrine is a powerful vasopressor used to treat hypotension, especially in cases like septic shock. Its strong vasoconstrictive effects make it an essential tool in both ICU and anesthesia settings, helping to maintain adequate blood pressure and perfusion.